In this video, we will be discussing about ataxic disorders. What is ataxia? Ataxia means clumsiness of the movements, which is clinically manifested by unsteady gait, and also there will be tremors. It is known as ataxia, and provided there is no motor and sensory deficit. If motor and sensory deficit is there, then the definition changes. So it will no longer be ataxia, it will be motor or sensory neuropathy or myopathy or whatever the cause is there. Types of ataxia. It is very important to understand the types of ataxia before we go on to the etiology. First of all, there is cerebellar ataxia, the most common type of ataxia in clinical practice. The most common type of ataxia which is which has many etiologies and it is inherited also. Cerebellar ataxia is the most common type of ataxia. What are the clinical features of cerebellar ataxia? I mean the features. First is the gait impairment. There will be gait impairment, of course, which is called as ataxia. What kind of gait? There will be reeling gait. Right. There will be scanning speech because there will be loss of coordination of the muscles of speech, that is these pharyngeal muscles and laryngeal muscles. There will be scanning speech because of nystagmus, that is eye coordination. Because of eye coordination problems, there will be visual blurring, there will be tremors, there will be incoordination of the hand movements as well as of the movements of other parts of the body. Now, second type of ataxia is vestibular ataxia or labyrinthine ataxia. By vestibular, we mean the vestibular nerve, right? Vestibular ataxia or labyrinthine ataxia. There will be again gait disorder, but there will be other labyrinthine features. The most common is vertigo. There will be no vertigo in cerebellar ataxia. Along with this, it will have lightheadedness and perception of movements. Whenever the patient will move, he will feel that his head is also spinning with that. That is a feature of vestibular or labyrinthine ataxia. Third kind of ataxia is sensory ataxia. See, there are three inputs to the cerebellum for coordination of movements. One is the sensory input from the eyes. Second is the sensory input from the vestibular nucleus and vestibular nerve. Third is the sensory input from the spinocerebellar tracts or the dorsal column. If there is involvement of the dorsal column, right, there will be sensory kind of ataxia. It is called as sensory ataxia. It is conventionally called as sensory ataxia. So this is something which needs to be remembered. We cannot apply logic in here that why it is sensory ataxia. It is conventionally named sensory ataxia whenever there will be involvement of dorsal columns. The joint and position sense means proprioception, vibration, position. All these sensations will be lost. There will be no sensory input to the cerebellum, and cerebellum will face difficulty in coordinating the movements. So it is called as cerebellar sensory ataxia, right? And the feature of sensory ataxia is there will be Romberg sign present. Obviously, there will be gait disorder. There will be tendency to fall. There will be difficulty in movements of the hands or the coordination of the hand movement or the movement of the feet also. There will be difficulty in maintaining equilibrium, but the characteristic finding is Romberg sign. Romberg sign is a sign to demonstrate sensory ataxia. It is not a sign to demonstrate cerebellar ataxia, right? In this, we will ask the patient to stand with his feet closed, and we will tell the patient to close the eyes. As soon as the patient will close the eyes, his ataxia will even more worsen. But in cerebellar ataxia, there will be no worsening of the ataxic symptoms. But in sensory ataxia, the patient will fall. He will tend to fall as soon as he closes the eyes, and that is Romberg sign. It is a sign of sensory ataxia. Cerebellar ataxia. Now let us defragment the cerebellar ataxia into its various components. Cerebellar ataxia can be of two types. That is focal ataxia, means a part of cerebellum, a focus of cerebellum is involved. So there will be focal symptoms, that is ipsilateral tremors. Along with it, there will be the signs and symptoms of the cause that is causing focal ataxia. For example, raised intracranial pressure, loss of consciousness, sixth, seventh, and eighth nerve palsy. Why? Because it exits just close to the cerebellum. Right? That is why there will be palsy of these nerves. Because it is focal ataxia, there will be some focal etiology. Focal etiology can be vascular, neoplastic, demyelinating condition like multiple sclerosis. Some inherited causes like Dandy-Walker syndrome and Arnold-Chiari malformation. These all causes can cause focal ataxia. Then there will be cerebellar ataxia, which is symmetric progressive ataxia. It is not focal. It is symmetric, means the whole of the cerebellum is being involved. It is progressive, means some progressive condition is underlying this. It will be recognized by bilateral tremors. It is not a unilateral condition, it is bilateral condition. There will be gait ataxia. Obviously, it is the cardinal sign of cerebellar symptoms, cerebellar pathology. Causes, some generalized cause like drugs. Which drugs? Phenytoin, which needs to be remembered, and toxins like mercury and lead. Right. There can be some paraneoplastic syndrome associated with bronchogenic carcinoma, some inherited ataxia. It is very much important. It needs to be remembered. Inherited ataxias, they will also always cause symmetric progressive ataxia. Right. So this is the division of cerebral ataxia on the basis of etiology. Now let us decode the inherited ataxias. Right. It is just classification. We are not going in the details of the ataxias because they will consume a lot of time, and I think another video needs to be uploaded for that. So inherited ataxia can be autosomal dominant, it can be autosomal recessive. In autosomal recessive, there are spinocerebellar ataxias. Right. There are various subtypes of spinocerebellar ataxias from 1 to 8. The most important ones are the spinocerebellar ataxia 1, 2, and 3. Right. So these three ataxias need to be remembered, and we will be discussing about these ataxias in detail in some other video. Second is the DRPA. It is also an autosomal dominant inherited ataxia. Its full form is dentatorubropallido-Lewisian atrophy. There are various parts of the CNS which are being involved in DRPA. So the signs and symptoms will be like that of pertaining to these specific areas of the CNS. Dentato rubro means there is something to be associated with dentate nucleus, red nucleus, and these two nuclei, they are involved in the coordination of the movements. Their efferent pathways are somehow related to the cerebellum. So the involvement of dentate nucleus, red nucleus, will cause ataxia. Pallido-Lewisian atrophy, there will be involvement of pallidum, means there is involvement of basal ganglia. Basal ganglia is involved in maintenance of tone of the muscles, maintenance of it coordinates the movements. So involvement of pallidum will cause dystonia, and basal ganglia is also involved in memory, so there will be dementia also. So in DRPA there will be very varied clinical manifestation, ranging from incoordination, ranging from hypotonia, ranging from dystonia to dementia, right? It is also an inherited kind of ataxia. It is studied under this topic. Third one is the episodic ataxia, right? Episodic ataxia, it is also inherited ataxia in which there is involvement of gene which codes for calcium channel. The gene name is CACNA1A, calcium encoding gene. Type 1 episodic ataxia is also there. So these two are the episodic ataxias, means there will be a sudden onset of symptoms of ataxia and nystagmus. For example, change in posture, exercise, these conditions may cause ataxia. So this is feature of episodic ataxias. Now comes the autosomal recessive inherited ataxias. Two very important, very famous, well studied kind of ataxias which are studied under the topic of autosomal recessive ataxia is the Friedreich ataxia and ataxia telangiectasia. Definitely these two disorders also need some different video. They are beyond the scope of discussion in this video. So this is all about the inherited ataxias, right? Ataxic disorders, and then we have studied cerebellar ataxia, and in cerebellar ataxia we have further decoded the inherited ataxias. Why? Because these are the important ones. That is all about this video. Thank you.